Good morning, my name is Seonaid Rodgers, and today I'll be introducing my project, evaluating the dose reduction potential for added tin filtration in paediatric non-contrast chest CT imaging. Firstly, I would like to thank my supervisors, Gina Atkinson, Martin Ebert and Cameron Storm, with a special mention to Rick Nezich, who has helped me a lot this semester despite having his own master's project. One of the key principles of radiation protection is that any justified medical exposure of radiation should be optimised or kept as low as reasonably achievable. Compared to adults, children are at greater risk to the stochastic effects of radiation for two reasons. Their highly proliferating cells make them genetically more susceptible to the effects of radiation. Secondly, their longer life expectancy means they have many more years over which to develop a cancer that may be induced by an exposure to radiation. This increased risk is demonstrated in this figure, released by the ICRP publication 60. You can see for children under the age of 5, especially females, are at a much greater risk of developing a cancer due to an acute exposure of radiation compared to the rest of the population. Additionally, CT, compared to other X-ray imaging modalities, delivers a significant radiation dose to the patient. Therefore, it is clear that dose optimization for CT is especially important for paediatrics. Traditionally, a standard amount of filtration in CT is used to decrease unnecessary patient dose, especially to the skin. This is done by the filtration reduces the very low energy X-rays that do not reach the detector and are instead absorbed by the patient. They do not contribute to the production of the image, but they do contribute to the patient's radiation dose. In addition to reducing the patient dose, standard filtration also aids in the reduction of a beam hardening artifact, which is caused by a soft X-ray beam. Now, the traditional amount of filtration depends on the manufacturer, but is usually between 5 to 10 millimeters of aluminium. Now, tin filtration is an additional 0.6 millimeters of tin added on top of this traditional filtration. Why tin filtration? Well, tin additionally absorbs low and intermediate energy X-rays, which filters out the low energy X-rays and increases the average beam energy. This is also called beam hardening. The tin filter was originally seen by the release of the Siemens Somatom definition flash, where it was used for the purpose of spectral separation for dual energy CT imaging. It was the release of the Siemens Somatom Force that saw the tin filtration being used for single energy, low dose imaging. In saying that, the tin filter is only available for 100 kVp or 150 kVp. This figure I've made with the help of Rick shows the beam energy spectrums of the 100 kVp beam with added tin filtration in the dark orange here compared to the standard filtration at the same kVp. You can see the overall beam intensity has decreased due to the heavily attenuating properties of the tin, and the beam energy has shifted to be a higher average beam energy. So tin filtration is currently being used for ultra-low dose imaging in adult CT. Clinical studies have found that the tin filtration can significantly reduce the patient dose without compromising certain diagnostic tasks. So these examinations where it has been proved beneficial include anatomy that have inherently high subject contrast. For example, interfaces between soft tissue and lung, some soft tissue and air, for example, lungs, sinuses, and bony structures. However, it is unclear whether the benefits that have been demonstrated in adults by tin filtration would easily apply to children. Children have a considerably smaller anatomy, therefore will attenuate much less X-rays. So will the benefits of increasing the X-ray beam and reducing those low energy X-rays that may actually contribute to the useful image, the benefits of tin filtration may be lost in children, especially considering that there is evidence to suggest quite the opposite, so that in fact reducing beam energy improves image contrast in paediatric imaging. Having a earthquake. I think it's just me, really. Okay, so the current literature for paediatric imaging using tin filtration. A clinical study by Bodell et al. Compared the tin filtration at 100 kVp compared to standard 100 kVp chest CT examinations. They looked at two groups of children, aged 0 to 5 years and 6 to 18 years. This was a retrospective study that aimed to match the CTDI values from both filtration methods. Although this study did not aim to quantify the dose reduction potential, they did find that the dose was reduced using the tin filtration for the age group 6 to 18 years. However, this can be explained by the large variation in patient sizes and not by the tin filtration alone. Another clinical study by Visa et al. Compared the tin filtration at 100 kVp to a lower beam energy at 70 kVp. They matched patient sizes by the thoracic circumference and found that despite a significant decrease in dose using the tin filter produces images of similar signal-to-noise ratio. This study also calculated organ doses using a Monte Carlo simulations, and they found, as expected, that the tin filter would also produce organ doses of a lower value. And overall, this study suggested that both the use of tin filtration and lower kVp produced significant diagnostic images at considerably low radiation doses for paediatrics. Now, a phantom study by Santharalingam et al. Tested all available kVp values, including the ones with tin filtration, on 3 various sized phantoms: a newborn, a child, 5-year-old, and an adult phantom. They found, in particular for the newborn, that the tin filter reduced the noise. So for a similar CTDI, they reduced the noise and improved the contrast to noise ratio. However, these values were not statistically significant, and therefore this study concluded that there was not significant evidence to suggest benefits using tin filtration for paediatric chest CT. This phantom study did not perform any external dosimetry measurements, simply took the value of the CTDI that is displayed on the CT scanner, which is automatically generated by the tube voltage and the reference tube current. Finally, a conference paper that was released by the European Society of Radiology, another phantom study, suggested that tin filtration should be used on paediatric chest CT. This study optimised a figure of merit, a contrast to noise ratio divided by the square root of the dose. Although some aspects of this paper were unclear, and I feel that this study did have some limitations, it importantly highlighted the discrepancy between the measured CTDI values and the displayed CTDI values. So there was a discrepancy seen when scanning the paediatric phantoms, however not when scanning the adult size phantoms. This is not surprising considering that the displayed value is calculated from a 32 centimetre sized phantom, when paediatrics would be 16 centimetres or less. Okay, so both clinical studies presented large variations in age and size categories, which could potentially blur the effects of larger children demonstrated in adults into the unknown effects of very small children. Only one of the phantom studies performed dosimetry measurements, and all other studies simply recorded the displayed value for the CTDI. In my opinion, the current literature is inconclusive in regards to the appropriateness of using added tin filtration on paediatric chest CT, and my project aims to address this gap in the literature. So, The aim of my project is to evaluate the dose reduction potential for added tin filtration for non-contrast CT examinations of the chest for various age and size categories, with a special focus on smaller size categories. A secondary aim of my project will be to determine whether there is a threshold size or age category below which tin filtration is no longer beneficial in reducing the dose, and hopefully propose an alternative method that is more dose efficient. My project plan consists of 3 main stages. Firstly, the construction stage, where I will be making paediatric chest phantoms. Once these phantoms have been validated, we'll be using them to take dosimetry and image quality measurements, and finally analysing this data to determine the dose reduction potential of tin filtration. A little bit more detail. During the construction phase, I will be 3D printing the phantoms with the help from my fellow master's students and physics staff at the Department of Radiation Oncology. We will be 3D printing the phantoms using materials that mimic the X-ray attenuation properties of structures in the mediastinum. Soft tissue, lung and bone can be constructed using polyurethane foam and PVC. Each phantom will need to have a small cavity for the insertion of a dosimeter, as well as a slice cavity for the insertion of an image quality testing tool. The data acquisition phase will involve measurements being made on the Siemens somatom force located at Perth Children's Hospital. A CT dose profiler will be used to take dosimetry measurements used to estimate dose metrics such as the CTDI vol and the size-specific dose estimate. Image quality measurements will be taken to allow the analysis of spatial contrast resolution, uniformity, and a figure of merit. The costs associated with my project will involve the manpower of the lovely people who are going to help me both construct and validate the phantoms, the radiographers who will help with the acquisition of the data, and of course the raw materials of the phantoms that I will be using to construct the phantoms. A very conservative estimate of the cost, including room for error, has been estimated at $2,000. I would like to highlight that these phantoms are not disposable, will become property of the hospital, and could be used in future studies. In conclusion, the current literature is not adequate in addressing the current literature is inconclusive in regards to the dose reduction potential of using added tin filtration on non-contrast paediatric chest CT, and my project aims to address this gap in the literature. It will be a phantom study that involves the construction and validation of various size phantoms with a specific focus on small patient sizes. Dosimetry and image quality measurements will be used to analyse the dose reduction potential of tin filtration. A secondary aim of my project will be to determine a potential threshold size category below which tin filtration is no longer the most appropriate method of scanning paediatric chests via CT. Ultimately, we would like to reduce paediatric CT doses and limit the associated risks of cancer due to this.
So you talk about validation of the phantom. What would validate the phantom?
Yeah, I believe that we scan them on the CT and validate them by comparing the CT numbers on the various tissues and compare them to the CT number that we expect those biological tissues to present when you scan them on the CT. I believe. Yeah.
Thanks for the presentation. So I was just thinking, so you talked about the aluminium filtration that exists,
Yes, standard.
and then you're adding tin to it.
Yes.
Do you think it matters which filter comes first, like the arrangement?
Yes,
Does
yes.
it make a difference?
Yes, definitely. So the aluminium always comes first, and pretty sure it can't be removed. Okay, it's dangerous for it to be removed. So the tin filter gets added afterwards for that additional filtration, and that one is deployable and can be removed, but it's important that the aluminium is always there first. Yeah.
Okay, so you cannot change the arrangement, but do you think it matters? Like, is it better to have tin first and then aluminum?
I'm unsure, but that would be something that we could look into. Yeah, definitely.
So in terms of dosimetry, what type of dosimeters?
We have at MTP we have a CT dose profiler. So we've got a pencil-shaped ionisation chamber, which can do simple dose measurements. But we have the CT dose profiler is capable of doing the CT-DI vol in one measurement rather than the 5 measurements, which is the standard method outlined in the AAPM task 204.
Any other questions?
And so when it's actually being used clinically, I
Yes.
assume you just define a protocol that includes the filter, and then when the radiographers load that protocol, it automatically
Does it. Correct. Yeah.
Oh.
Yep. So they're just selecting that tin filter, unless they have reason not to.
Yep.
I believe.